Hi everyone, my name is Kristen Huff. This is my Technology and Nursing Administration presentation. So a quick overview of Newark Wayne Community Hospital. This is a rural hospital founded in February of 1921. This is a hospital that makes up one of the 5 hospitals of Rochester Regional Health. Offers a variety of inpatient and outpatient services to the local community. For this project, I interviewed 3 informatics specialists. The first was an informatics nurse, Rhonda Camp. Rhonda had, in the past 2 years, transitioned from a staff nursing role to an informatics nursing role, and so I was able to get a pretty good rounded view of her views of the advantages and disadvantages. So some of the advantages she saw of CareConnect was the increase in nursing efficiency. She also felt that the BPAs in CareConnect were a huge advantage for the healthcare team. This helped reduce patient errors and increase patient outcomes. Another advantage she saw was the increase in communication. So anytime a change is made in CareConnect, this has to go directly to the informatics team and an advisory group just to add band-aids to on addressing change. In Epic, this had to go to a nursing AG and through the entire process, so this improved communication to all the teams that it may affect. Some of the disadvantages were building, so if the builds were not done appropriately, the data would not be appropriate or correct. Rhonda had recently worked on a report for the anesthesiology group. When this report was pulled, the data was not correct because the build was not correct in CareConnect. So this was something that was frustrating for her. Another thing that she saw as a potential disadvantage was that the number of affiliates using Epic we're all using one system, so the workflow may be different. So the workflow in Epic may not match the actual workflow. The next person I interviewed was a privacy officer, Kelly Shea, who is the health information manager in the Eastern region. The focus of her job is to maintain patient privacy. So some of the advantages she specifically talked about was the ability to easily view how long someone had viewed a chart, what they had clicked on, how long they had looked at it, and this was a way for her to audit and ensure that patient privacy was maintained. Another advantage we talked about was electronic records and the ability to view charts from anywhere. The great outcomes that it had for patients, as providers from anywhere could view their charts and view their medical records, so there wasn't missing pieces as we used to have when we had paper charting. Some of the disadvantages she talked about were on the other hand, accessibility. More people accessing charts created the potential for more, improper use. Because Kelly not only maintains privacy, but she also works closely with the HIM7 initiative. We talked a lot about scanning and how this is both an advantage as well, because information can be scanned directly into the chart within 1 hour is the goal of the time it was completed. Also, somewhat of a disadvantage is she has to spend a lot of time auditing to ensure that scanning is done properly and things are labeled correctly. The last person I interviewed was an informatics leader, Amy Carey. A lot of what the discussion was based around with Amy was the advantages and disadvantages of the electronic medical record based on integration. So Amy is big on integration of other technology. So we talked a lot about in the ICU the improving efficiency for nurses as the bedside monitors feed directly into Epic. We also talked about a project Amy was currently just finished working on where Epic loads the current unit census directly into Kronos, which is the timekeeping app, and allows leaders to pull productivity reports in real time based on the employees who are clocked in and the current unit census. So integration was something that was big with Amy. She's big on maximizing technology and using it to our fullest capabilities. Another advantage we talked about was LexiComp and the way that Epic has, in the electronic medical record, has allowed us to access information and education directly in the patient's room at the time of service, so we are not having to, leave and come back and things like that. Some of the disadvantages she talked about were maintenance. So maintenance with all of the technology is difficult, with all the different affiliates and different workflows. It is difficult to keep people all on the same page. And that was really the biggest disadvantage we talked about. She also mentioned that sometimes people become discouraged when there's change in Epic and it doesn't go successful the very first time, although that isn't necessarily a disadvantage, but just the way change is. An overview of the technology and information system. So Citrix is a secure workforce. Epic and CareConnect are our electronic medical records. Kronos and the Kronos mobile app and Employee Self-Serve are all timekeeping applications. SharePoint is the employee portal. Workday is the leader portion of the employee portal that allows you to run reports on your team. SafeConnect is our event reporting. MedSelect and OmniCell are the two medication dispensary systems used in the Eastern region. Force is finance and budgetary application. HLC is employee education. LexiComp is medication and procedure education for both employees and patients. GE monitoring and bedside monitoring, which feeds directly into Epic. SoftTrace is what the lab uses. PowerPath is what pathology uses. Cerner Bridge is for bedside lab draws. Microsoft Office, we all know. NurseCall is the call system used in the Eastern region, allows real-time monitoring and location services of the nurses and techs, as well as automatically shuts off call bells when someone enters the room. Celerity is batch scanning technology. Work orders is technology that allows facilities to see work orders directly when they're entered so they know what needs to be done. And then Alaris Pumps and other bedside technology as well. A quick overview of Epic. Epic or CareConnect went live in Newark in 2012. As a nurse who was able to see both paper charting and be here for the go live of Epic, I've been able to really experience a lot of the improvements in patient care and outcomes. So there have been huge improvements in patient safety and medication errors and things like that. The advantages are numerous, so increased provider efficiency, increased continuity and access to records, higher patient safety outcomes, increased education and availability of information to the nurse and both the patient in the room in real time. And then some disadvantages like privacy concerns, although when we had paper charting, there was really no way to track or audit. When with electronic records, we are able to regularly audit and track who is in a patient chart. So that's, I feel like, maybe an advantage as well. Being a large system with 5 hospitals and many practices, having one EMR is difficult because of the different workflows. So that may be seen as a disadvantage as well. Progress and status. So at Newark, we've seen huge improvements in care and safety in the last 7 years since transitioning to the electronic medical record. One example is device utilization report. So we are able to pull reports of all the devices like Foley catheters in the hospital. They are investigated every single day, and if the provider determines that it is not necessary, it's removed. And this has really helped decrease our device utilization, but also our catheter-associated UTI. When interviewing the 3 informatics team members, none of them had clear understandings of the incentive programs that were used, although they all seemed to know that there were originally incentive programs in place. But it was unclear how much of the incentive programs really determined the decision to go to CareConnect, or if it was just really the system's goals and ideas, mission. For privacy and confidentiality, after speaking with Kelly, it was really clear that maintaining privacy is difficult, but within the system and even Newark, there are many safeguards in place, such as breaking the glass. So in order to open the chart of an employee, or a private chart, you have to enter your password and also a reason of exactly why you were entering the chart. There are also a privacy council that investigates any questionable access and audits, both electronic and manual audits that happen regularly to maintain privacy. So for this project, we had to investigate 4 different technologies that are used to increase patient care and outcomes. So the first one I looked at was the EKG machine. So an EKG machine is an essential part of the initial evaluation for patients presenting with cardiac complaints, providing healthcare providers with information on the structure and the function of the heart. So essentially electrodes on the chest that record electrical impulses. In 1842, the first electrical activity from the heart of a frog was recorded, and in 1887, the first electrical activity from a human heart was recorded. It wasn't until 1954 where the standard 12-lead EKG as we know it was invented. The EKG machine really improves patient care because it is the simplest and fastest test to evaluate the heart with little to no risk of the patient. So this is completely non-invasive. The only risk for really any injury is irritation from the stickers, and this can give us a lot of information with very little invasion of the patient. The second thing I investigated was the bladder scanner. So this is an ultrasound machine that specifically ultrasounds the bladder to determine the amount of fluid in the bladder. Ultrasound machines were introduced in 1950s but had been used for various different organs and volumes. Early studies of ultrasound measured many things like urine volume, but required separate calculations and was very complicated, where today we can simply take the wand, point it at the bladder, push the button, and it will tell us exactly how much is in the bladder. This has really improved nursing care and patient outcomes because we're not, guessing or putting Foley's or straight cathing patients who probably don't need it. We can get an accurate read of the bladder and then determine if there's anything needed from there. The third thing I looked at was an Alaris Smart Pump. So this is simply a pump that allows programming to safeguard the medications given. IV technology stems from studies on cholera in 1831. IV therapy was further developed in 1930s but was not widely available until 1950s. The first ambulatory infusion pump was not created until the late 1950s and was used primarily for chemotherapy. It wasn't until the early 2000s that smart pumps were born. These pumps provide pump history, medication error alerts, remote programming, software interface, patient identifiers. So these allow nurses to administer medications without counting drip rates, saving time, without causing harm or making errors, and they provide safeguards, unchangeable limits, which can prevent dosing errors and increase patient safety. The last piece of technology that I looked into was a BiPAP machine, or non-invasive ventilation. This is something that administers through a face mask or nasal mask airs, usually with oxygen added. This is not a new intervention. There are studies back into the 1800s where the devices were used with positive pressure on dogs that had created tension pneumothoraxes, so these were discouraged in use. Again, in the 1930s and 40s, literature has some description of positive pressure ventilation techniques that did not gain acceptance either. It wasn't until the 1980s that NIPPV gained some acceptance with chronic use, and now recently with both chronic and acute use. NIPPV allows for decreased intubations, oftentimes better recovery times, decreased use of ICU beds, and therefore decreasing ICU delirium as well. Okay, so in summary, having the opportunity to really take a deeper look into some of the technology that we use every day in work really was helpful for me to step back and understand how far we've come. Even in my time as a nurse in 7 years, we've really come so far, just from paper charting to electronic medical records and so many more things. All the technology I just went over, the EKG machine, the bladder scanner, smart pumps, and BiPAP or NIPPV are pieces of technology that allow healthcare workers to provide quality care with minimal invasion. It's often, taken for granted how much technology can allow healthcare workers to do and to provide better care and better outcomes for our patients. So a reflection. This experience has been extremely eye-opening for me. Throughout this course and this project more specifically, I've had the opportunity to build relationships with the informatics department, to really learn about the EMR and all the technology that we have at our fingertips, things that we take for granted every day, but I really got to, see the ins and outs of them and what other people do every day. I also gained the opportunity to really spend time with a privacy officer and learn so much about how we maintain patient privacy, more than just, the direct HIPAA stuff that we deal with every day. I always knew that there were things in place to keep people's information private, but I really learned a lot about the policies and all of the councils and auditing that is done. This project and course in general has really allowed me to see how important technology and partnering with the right people is, how it's so critical to my leadership role and my progress as a nursing leader. Here are my references. Thanks.